Assalamu alaikum. First of all, I'd like to thank my professor, Dr. Hamida Professor Hamid Tamam, for this trust and great chance to share my little knowledge with my professor and colleagues. So many thanks for our professor, Dr. Maher Al-Assal, and Professor Hisham Al-Qadi, and Professor Maysara and Professor Shazli for your presence. Shoulder instability, some like it soft, I like it hard. So shoulder joint, it's ball and socket joint. It's consists of head of the humerus with the glenoid, surrounded with the labrum and capsule, and involved in ligaments and rotator cuff and biceps. Biomechanically, glenoid and labrum and glenohumeral ligament capsule have important static stabilizer rule, and rotator cuff, biceps, and deltoid have an important dynamic rule. It's the most mobile joint, so it is the most dislocatable joint in the body. Glenohumeral dislocation affects 1.7% of the population, according to Antonio in 2001. This is the first patient is inferior subluxation. The second patient is anterior and posterior dislocation. So it's multidirectional instability. It's not our topics today. Today we are going to talk about the recurrent anterior shoulder instability, TOPS, the rheumatic unidirectional Bankart surgery. Systematically, we have to ask about the trauma, direction of instability, voluntary or not, since how far, and luxation and subluxation. We have to evaluate the patient regarding to the age, the gender, mechanism of injury, number of dislocation, occupation, level of activity. The most important point in evaluation is examination. We have to examine the patient neurovascularly, range of motion, passive and active, hyperlaxity in shoulder. The hyperlax patient, it means that external rotation with elbow outside more than 85 degrees. We have to test rotator cuff, and we must do special test for anterior stability. Apprehension test is the most sensitive and specific test for anterior shoulder instability. We do abduction with gradual external rotation. When the patient feels pain and apprehension, we have to stop. You will dislocate the patient. Load and shift sulcus sign is also added for the examination. We have to assess the patient radiologically, AB, near, and Bernago view. Here we see the Hill sac lesion in AB, inferior subluxation, and anterior shoulder dislocation. Also, in Bernago view, we can assess the glenoid ball loss and Hill sac lesion. So, CT with this view, we can assess the glenoid ball loss with circle method, and MRI, we can need MRI for liver injury. In patients above 40 years, we have to evaluate the rotator cuff tear, and MRI, it's better to do it in the first week after dislocation. It's better with effusion in visualization of the MRI. In 2022, I go to in my first fellowship in Basel. I met Gilles Falch, which is the previous fellow of Latarjet, and I want to follow him for a time, but unfortunately he's retired at this time. So he advised me to go to Geneva for Alex Liederman. So you have to know the past, understand the present to make the future. If it's the first time dislocation, you have to conserve sling for 5 to 3 weeks, depending on surgeon preference. Hovles in 1996 concluded that half of the patient between age 12 to 40 years with follow-up, with 10 years follow-up had no recurrence. So more than one time dislocation, surgical treatment is recommended. We have a risk factor for recurrence. Patients with age less than 40 years are 13 times more liable for recurrence. Males are 3 times more liable for recurrence than females. Glenoid ball loss, Hill sac, greater tuberosity fracture are risk factors. Hyperlax patients 3 times more liable for recurrence. Contact sport occupation, anterior labrum, periosteal sleeve avulsion, and axillary nerve injury also risk factor, as stated by Olds in 2015, as we see here. So upon defect, 100% of the patient with recurrent shoulder instability have Hill sac lesion. Hill sac lesion, it means that we have posterior depression. We have posterior depression in the humeral head. So, glenoid in 2014. Bipolar bone loss is the next expression. I mean that Hill-Sachs accompanied with bony Bankart. So we have to measure the glenoid bone loss with a circle method, and if the glenoid bone loss is more than 15%, it's critical, and if it's less than, if it's between 10% to 15% subcritical, according to Abdullah Hashim from Barcelona Shoulder Group in 2024. Glenoid tract, it's a new concept, dynamic interaction between the humeral head and glenoid bone defect. It's the distance of the glenoid through which the humeral head move. So if we have small Hill-Sachs, it's on track. And if we have large Hill-Sachs, it's off track and engage with the glenoid. As we see here, it's large Hill-Sachs, so it will engage with the glenoid anteriorly, which is described by Yamamoto in 2007 and Giacomo Giovanni from Roma Shoulder Group in 2014. In 2024, Emilio Calvo from Madrid Shoulder Group concludes that the higher the number of dislocation, the higher the off-track lesion. So the question up to our mind, we will do soft tissue procedure or bony procedure. We'll do Bankart, we'll do remplissage, or Bankart with remplissage. We'll do dynamic stabilization of the shoulder with long head of the biceps. We'll do Latarjet. We'll do free bone block. So we'll answer this question later. But first, if the glenoid bone loss less than 15% with on-track lesion, I mean small Hill-Sachs, so we'll do arthroscopic Bankart repair. And if it's less than 15% with off-track lesion, I mean large Hill-Sachs, we'll do Bankart with remplissage. If the glenoid bone loss is more than 15% with on-track, we'll go for Latarjet. And if it's more than 15% with off-track large Hill-Sachs, we'll go for Latarjet. Then we must test the patient after the Latarjet. Maybe the off-track lesion become on track. So we have to test after Latarjet. If still off track, we'll go for Latarjet with remplissage. In 2007, Pascal Bouliou from Nice Shoulder Group, he published a nice score, Instability Severity Index score. And first this score, he's 10 points. He depends on many factors, age and type and degree of sport, Hill-Sachs, or glenoid bone loss presence and hyperlaxia of the patient. First at 2007, it's more than 6, he will go for Bankart. More than 6, he will go for Latarjet. Less than 6, he will go for Bankart. But nowadays, in Stability Severity Index score modification, less than 4, he will go for Bankart, and more than 4, he will go for Latarjet. So, in 2019, it's a nice systemic review from Merve, from Dublin Shoulder Group. It's 9 study with 822 patients. It's assess the long-term result of Bankart. And functional score, raw score 87, satisfaction score 86, with arthropathy 60%, recurrence more than 30%, and revision rate 17. And if we look for another systemic review from the same Dublin Shoulder Group at 2019, for the assessment of the long-term result of Latarjet, 13 study with 865 patients, the functional score is better, and the arthropathy is less than 40%, and recurrence 8%, revision rate 3% with Latarjet. So, who is the candidate for Bankart repair? Non-contact sport, subcritical glenoid bone loss in the very early stage of instability. So we can't do a Bankart repair for a patient with more than 5 to 10 time dislocation, or coming after 3-4 days. You will not find a label. Advantages of Latarjet: low recurrence rate, long-term result, best bone procedure, restore complete range of motion. And this concept is important that the patient most of time he have the concept of limitation of the movement with Latarjet. But it's a difficult surgery, need a learning curve to have the best result. There is this triple Latarjet effect, bone block effect, hammock effect by lowering the subscap, and sling effect by conjoint tendon. So our new technique, we do the classical open Latarjet, we through deltopectoral approach, we stomize the coracoid and split the subscap, and then we do exposure for the glenoid and preparation of the glenoid, and coracoid process transfer and fixation. What we add? we add reinforcement of the labrum into the glenoid by suture anchor, and then reattach the capsule to the CA ligament with suture, reduce the humeral head posteriorly in elevation, abduction, external rotation during capsule tensioning, which give us good range of motion postoperatively. Take home message. The patient above 40 years with recurrent shoulder instability, evaluate the rotator cuff tear. Take into consideration risk factor for recurrence. Glenoid tract concept, the best to express bone loss. Instability severity index score, it's your guide. A long-term follow-up, Latarjet is better, capsule labor reinforcement, add biomechanical benefits, and I have to thank all of my colleagues in our department and professor for the continuous support and help, and many thanks for all of us.